Hello and welcome to this lecture on fatty acids and neurodevelopment, where I will discuss the role of DHA, docosahexaenoic acid supplements, and their impact on cognitive and other outcomes. So in this lecture, I want to give an overview of fatty acids. What are they and what do they do? And consider why they are so important in preterm infants and other sick newborn infants. Think about some of the challenges with intravenous lipid emulsions, and also think what else we might need to give in combination with fatty acids, so compounds such as choline. Briefly touch on whether there might be enough fatty acids in breast milk, the benefits, risks of DHA supplements and whether we should give them or not, thinking particularly about outcomes such as necrotizing enterocolitis, lung disease, bronchopulmonary dysplasia, and also ROP, retinopathy of prematurity. And importantly, obviously think about neurodevelopmental and cognitive outcomes. So what are fatty acids? Just going to do a little bit of biochemistry, but reassure you, you don't really need to try and remember this. You all know that the diet is made up of macronutrients and micronutrients. And macronutrients are proteins, fats, and carbohydrates, and probably water. And there are lots of different fatty acids, and they are either saturated or unsaturated. And this simply means that if they're saturated, they do not have any double carbon bonds, symbolized here by this little two lines here. But if they're unsaturated, they have a double bond. And the position of the double bond in the molecule tells you whether they are called a N3 or omega-3 fatty acid or an N6 fatty acid. Now, you may also have heard the term essential fatty acid. So an essential fatty acid is something that must be provided in the diet because humans cannot make it. And the examples of essential fatty acids that are important for neonates are alpha linoleic acid, which is an N3, and linolenic acid, which is N6. And these fatty acids provide energy and absorption of vitamins, as well as multiple other molecular neurological impacts. The metabolism of fatty acids is particularly complex. And so there are lots of fatty acids with lots of different complex names. And as I said, fatty acids provide multiple functions in the body. They're involved in cell membranes, very high levels in the brain and the retina. You need fatty acids to make many hormones, and they're also involved in many inflammatory processes. And here are some types of fatty acids. You don't need to remember any of those names. Dietary fatty acids are either provided in intravenous lipid emulsions. They may be added to formula milk. They are present naturally in mother's own milk and donor human milk. But they may also be provided as supplements, oils, which you can add to enteral feeds. So what do you need to understand fatty acids? Well, fats, oils, these provide a major energy source. And without adequate energy, it's impossible for the brain to grow and repair itself. As I said, you need essential fatty acids because humans can't synthesize them. So inadequate essential fatty acids will also harm brain growth and repair. Fat metabolism is abnormal in high-risk infants. And so if we provide an inadequate ratio, an inadequate dose or timing of fatty acids may also harm brain growth and repair. And fatty acid metabolism produces a whole range of pro and anti-inflammatory mediators. So inadequate or excess fatty acids might lead to higher rates of sepsis, retinopathy of prematurity, bronchopulmonary dysplasia, and NEC. And all of those conditions are associated with worse brain growth and repair. So fatty acid metabolism is critical for understanding development in preterm infants. As I say, you need essential fatty acids in the diet. These are either alpha-linolenic, N3, or linoleic, N6. But also there may be some fatty acids that aren't essential, so we call them non-essential. So you and I, if we're healthy, can make them fine, but these become conditionally essential under stress. So under stress, synthesis of these fatty acids from the alpha-linolenic and linoleic may be suboptimal. And so conditionally essential fatty acids might involve docosahexaenoic acid and arachidonic acid. We can elongate your essential fatty acids, so you add extra molecules, and this is how you form DHA and ARA. And as I say, DHA is essential for neuronal tissues. So you can already start to see that metabolism is very complex. And I think it's fair to say that it's very poorly understood by the majority of neonatologists. Why does this matter? Well, there are strong associations between reduced DHA, both as a biochemical measure, but also in the diet. Strong associations with impaired cognition and behavior in childhood, later life brain function as an adult, retinopathy of prematurity. And this, as I say, is because the functions of DHA are multiple. It's involved in neurogenesis, neurotransmission, and antioxidant activities. And the clinical studies are really quite complicated, and understanding them is not straightforward, but it's clear that excess DHA can cause harm, too little DHA can cause harm, and an incorrect arachidonic to docosahexaenoic acid ratio may also cause harm. So major concerns for neonatal practice, and we need to make sure we get this as right as we can. So how much do you need in healthy life? Well, infants need probably around about 100 milligrams a day. The recommendation for pregnant and lactating women from a number of professional bodies is that women need around about 200 to 300 milligrams a day. And of course, the best way of getting this is via the diet rather than as supplements. Infants can get good levels of fatty acids from breast milk, and adults we can get it from deep sea fish, but also cod liver oil and seaweed. Now, given that fatty acids are so important for pregnant women, what should we do about supplements? Should we be recommending routine maternal supplements? But actually, the opinion on this is divided. And if we are to use supplements, there is also no agreement on what sort of supplements we should be using. Should we be using fish oils or algae sources? And I'll come back to this later, but I just want to highlight that the average amount of breast milk DHA is about 2.3 grams per 100 grams of fatty acid, and we'll come back to why that might be important. Now, there are wide variations across the world between different populations, countries, diets that mean that fatty acid content of breast milk is highly variable. And within your own populations, you will have some mothers with very high levels of DHA in breast milk, maybe mothers who eat a lot of fish. And you'll have some mothers with very low levels of DHA, maybe mothers who are vegan and do not eat animal products. So it's very difficult to make global recommendations for this. Which infants and children are at highest risk? Well, preterm infants are at risk because they have an inadequate supply, both parenterally and enterally, and that goes for quantity and quality. And this is important because, as I say, fatty acids are involved in metabolic response, growth, incorporation into tissue, and the function of all those tissues. And not only do preterm babies have an inadequate supply, they also have higher demands because of their rapid growth and their pro-oxidant and inflammatory stresses that they suffer. It also seems possible that other sick newborn infants, such as those with hypoxic ischemic encephalopathy, may benefit from fatty acid supplements. There is also concern that low dietary fatty acid intakes in infants and children may be associated with worse outcomes. So children who have what we might call poor diets or drink milk with low concentrations of fatty acids. And there may also be a need for extra fatty acids in infants and children with high demands, those who are sick or perhaps have complex metabolic problems, or even neurodevelopmental disorders. And there are studies looking at this, but none of these give very clear, conclusive results at this point in time. So how do you know if your baby needs more fatty acids? Basically, you won't. There is no simple blood test that you can do to tell you whether you should supplement that baby or not. Therefore, what do we need to do? We need to ensure that intakes are adequate. We need to make sure that we use intravenous lipid emulsions in very preterm babies. We need to encourage the use of mother's own milk and encourage the mothers to have a good diet. We want to use formula that is supplemented with fatty acids, particularly in very preterm. But whether we should be giving maternal supplements is quite controversial, and whether we should give neonatal supplements is also quite controversial. We probably should give dietary advice to mothers where intakes are low, so that's particularly for vegetarian and vegan women. Infants where their diet lacks a good source of fatty acids, for example, diets that are low in milk, egg, meat, and fish, and particularly in populations with low intakes of fatty acids. So, do we have a problem in preterm babies? The answer is yes. We do not have enough research and we do not have enough knowledge. But it's clear to say that suboptimal practice then is universal. When we look at fatty acid profiles biochemically, every preterm infant is abnormal compared to the fetus or the full-term baby. And this is because, as I've said, that preterm birth represents an interruption to fetal metabolism and the elongation of your essential fatty acids into your long-chain polyunsaturated fatty acids. And also preterm babies, as we heard in the previous lecture, don't have very much adipose or fat tissue, so they do not have a reserve of fatty acids. It's true to say that no parenteral or enteral regime is optimized, and these deficits are associated with lung disease, sepsis, and retinopathy. So evidence that lower intakes result in higher rates of retinopathy, sepsis, and BPD have been presented in studies. So I don't want to get too complex about the biochemistry, but just to kind of help you understand, there is two key pathways. These are the N6 or the N3 pathway. This determines where the double bond in the molecule is. The N6 pathway starts with linoleic acid, which is progressively elongated to form arachidonic acid. And arachidonic acid produces a range of compounds called eicosanoids, which are pro-inflammatory. The N3 pathway is the alpha-linolenic pathway. Again, enzymes elongate the alpha-linolenic acid to form two important compounds. The first is eicosapentaenoic acid, which will form eicosanoids and may be pro-inflammatory. But further elongation results in the formation of docosahexaenoic acid, or DHA, which produces resolvins, which tend to be anti-inflammatory. But importantly, these elongation enzymes are the same for both of these. And therefore, if you overload the N3 pathway, you may prevent the formation of adequate N6 compounds. So you can see this is very complex. Involving two different pathways, lots of different compounds that are produced, eicosanoids and resolvins. And we need to keep this balance right, because you can see that if you get this balance wrong, you may be associated with a pro-inflammatory state. So, long-chain polyunsaturated fatty acids are a major component of the central nervous system and the retina. There was a lot of placental uptake in the third trimester. As I've said, preterm infants are deficient. They lack placental supply. They have low fat stores. They have immature digestive and metabolic functions. And the composition of intravenous lipid emulsions that we use are suboptimal for preterm babies. None of the intravenous lipids that we use were designed for very premature babies. So there are two key essential fatty acids. There are lots of different steps. You don't need to remember any of the names of these compounds. But you can see that all of this is incredibly complex, and every single one of these molecules you see here has biological activity. And Carrie Martin reminds us that none of these fatty acids are inert. All of these are doing something. So when we want to consider the addition of extra fatty acids or the ratio, this becomes very, very complex to understand what might be the right studies to do. If we look at intravenous lipids, the common and intralipid that's been used the most is one called intralipid, which is all formed from soybeans. And this has a very high amount of alpha linolenic acid and linoleic acid. So it's a great source of this, but it doesn't contain any extra DHA. Linoleic has some soybean emulsion, but is largely made from olive oil. So this results in lower linoleic acid and alpha linolenic compared to intralipid. A very common emulsion, particularly in the UK and Europe at the minute, is SMOF. This is made up of soy, medium chain triglyceride, which is actually coconut oil, olive, and fish. So 4 different compounds. And compared to intralipid, this results in higher levels of arachidonic acid and DHA, which we might assume would be good. But it also results in high levels of eicosapentaenoic acid, which may be pro-inflammatory, and a disordered balance of arachidonic acid to DHA. So when we use SMOF, we start to disturb this balance, this careful ratio. And then there is a product called Omegaven, which is all made from fish oil. This has the highest levels of DHA, arachidonic acid, and eicosapentaenoic, but results in a very abnormal ratio, very high levels of DHA. So this is not recommended for routine use, but might be used in certain infants with very complex liver disease. What do we see in babies who are fed on intravenous lipid emulsions? Well, we see this dramatic drop in DHA and arachidonic acid in the first week. It doesn't matter which one you use, that these levels go down. But in intralipid particularly, we see this increase of linoleic acid up by 3 and a big increase in alpha linolenic times 20 on intralipid. What are the mechanisms? We don't really understand, to be honest. We have inadequate stores, we have increased demand, we have immature enzymatic pathways, and can still make DHA, but not probably in adequate levels. And probably all of the fatty acids are not supplied optimally in parental nutrition and enteral. Fish oils, which might seem to be a good idea, result in higher increases in linoleic acid. And they have more DHA, which might be a good thing, but much, much more eicosapentaenoic acid, which may be harmful. And when you use fish oils, you get a drop in the N6 to N3 ratio and a drop in the arachidonic acid to DHA ratios, again, which may not be optimal. So what is going on? Well, a lot of this appears counterintuitive, and I'm certainly not one to understand quite the complex biochemistry here. When you use fish oil, we seem to worsen the arachidonic acid deficit despite the fact that we give more of it. And even though you're giving much more DHA levels still low. Now, this may be because babies are using the same enzymes to desaturate and elongate these fatty acids. So there's probably competitive inhibition for the fatty acids and incorporation of these fatty acids into cell membranes. So something really not very right is going on here. Fish oils seem to worsen the arachidonic acid deficit, dramatic increases in eicosapentaenoic acid, and reverse the arachidonic acid to DHA ratio compared to a neutro. Again, probably not a good thing. So Cami Martin and others have summarized these changes in terms of the N6 molecules, intralipid putting a lot of dramatically increasing linoleic, SMOF dramatically decreasing arachidonic, intralipid and linoleic decreasing docosahexaenoic acid levels, SMOF and other fish oils dramatically increasing eicosapentaenoic acid, and also worsening the arachidonic acid to DHA ratio. So very complicated. What are the randomized controlled trials telling us? Well, overall, using a fish oil or a SMOF doesn't appear to reduce BPD, retinopathy, or NEC. So no strong evidence for use generally, and no very strong evidence for use in PN-associated liver disease, although we do tend to use it. In a secondary analysis of a very large DHA trial, they saw a reduction in arachidonic acid was associated with increased rates of retinopathy. And there are evidence from other studies showing that fish oils are associated with high rates of sepsis and lower oxygenation. And that might be because although we're very focused on DHA for the brain, arachidonic acid is involved in alveogenesis and many more metabolic processes. So these low levels are of major concern. So although fish oils are widely used, they are not without significant risks. Now let's step back and think, what else do babies need in their diet to grow aside from the fatty acids? Well, of course, you need every nutrient to grow. You need all of your micronutrients, vitamins, trace elements. And we know that the bionutrients provided in breast milk, such as hormones and IGF-1, are very important. Iron is critical for brain development. But of course, you're going to need sufficient intakes of iodine and zinc. But to make these important cell membranes, these phosphatidylcholine, which you see combined into the phospholipids in these cell membranes, you need this compound called choline. And choline is a bit like a B vitamin, but the structure's a bit different from a vitamin, and humans can synthesize it a bit. So it's not an essential nutrient like a vitamin, but it probably functions a bit like a B vitamin. And choline, we have a very high demand for choline in the third trimester. It's involved in DNA methylation. It's a precursor of acetylcholine, so like to have multiple neuronal functions. It's a substrate, as I said, for phosphatidylcholine and sphingomyelins. It's an important dietary source of methyl groups, so it's likely to be involved in epigenetic effects. And there are numerous animal studies, for example, showing that maternal choline supplements in rats improves memory and attention. So choline clearly a very important compound involved in multiple metabolic processes. I just want to show you this study, which is quite an interesting and very unique study. This was conducted in completely healthy pregnant women. So these were babies who were going to be born as healthy term infants. And they randomized mothers to a diet of 480 versus 930 milligrams of choline a day. And this was a very complex intervention because they had to provide all the meals to these mums during the third trimester of pregnancy. So a massive study. And the outcome of this study was to look at the impact of choline on processing speed in infants and visuospatial memory. And they did this by measuring reaction time. And what they basically showed overall is this relationship between the speed of reaction and the amount of choline that the baby's getting, a better reaction time in the babies on the higher intakes of choline. So choline supplements seem to be beneficial. Now, this was in completely healthy term infants. This is probably the only nutritional intervention I've ever seen in normal healthy infants that shows a benefit. Now, these differences didn't persist after infancy, I don't think. And this doesn't mean that we should be going around telling women to take extra choline, but I think it does show us that choline is probably a very critical nutrient in the third trimester. Does this importance apply only to preterm babies? Well, it seems that infants suffering from hypoxia ischemia also appear to have very low levels of HIE. This is quite a complex observational study, but I'd recommend you all take a good look at it. And they looked at babies with moderate to severe HIE, and they compared them to infants with mild HIE. And they also looked at infants with a good outcome and those with a poor outcome. And of these, 9 of these had cerebral palsy. And so the infants with HIE who have a poor outcome are depicted in red. And here you can see levels of linoleic acid and other omega-3s and different ratios. So don't get bogged down in the difference. But what we can see here is that the N3 index, the amount of DHA, was lower in the infants with HIE who had a poor outcome compared to those with a good outcome. We saw lower levels of the enzymes delta-6 desaturase was lower in those with severe HIE. And the lower levels of linoleic acid were associated with those with a poor prognosis. So lots of complex biochemistry, a small study, but again persuading us that reduced levels of DHA might be associated with poor outcome, perhaps because there just isn't enough to make new neurological tissue. And so there is a potential for DHA supplementation to improve neurologic outcomes in babies with severe HIE. How much do babies get? Well, We can look at the amounts transferred in the placenta by measuring cord blood at term. We can look at breast milk. But what I want to highlight to you here is the typical levels of arachidonic acid and DHA in the breast milk. So typical levels are adequate. But what we see in donor human milk is actually very low levels of DHA. So maybe DHA levels are affected by pasteurization. But also importantly, women who consume a typical Western diet with low intakes of fish oils and other animal fats also seem to have a very low percentage of DHA in the diet. So why not just give the baby some extra DHA to be safe? Well, that's because DHA appears on its own to increase the risk of BPD. So in this large Australian study published 5 years ago, they saw an increase in the rate of BPD when babies were given DHA supplements compared to placebo. No impact on any other outcomes. A very similar study was conducted in Canada at the same time. That was stopped early because of these concerns. This also seemed to show an increase in BPD. There was no clear impact on outcomes such as retinopathy and sepsis. So there has been a concern that giving extra DHA might increase the risk of BPD, but a more recent meta-analysis that I will show you suggests that if you just look at serious BPD, there may not be an impact. But importantly, these trials did not give arachidonic acid in combination with the DHA. They just gave DHA on its own. And it seems likely that we need to probably supplement both of these fatty acids, but there are very few trials for us to know what to do. So I've told you that blood concentrations of fatty acids are abnormal from day one. These lipid emulsions were designed for adults, but it takes time to establish milk feeds in preterm babies. So there's this critical period where we're probably not providing enough fatty acids. The secondary analysis of the large Australian trial of DHA supplementation looked at the different types of intravenous fatty acids. Again, they showed you what I presented before, that in the first postnatal week, you see these very large drops in DHA and arachidonic acid, but also abnormal fatty acid profiles with different intravenous lipid emulsions. What is going on here? We simply do not understand the metabolism of fatty acids in preterm infants. We need to know a lot more before we can make recommendations. Are preterm infants therefore deficient in DHA and RA? Probably. Are the proportions important? Yes, probably. It depends where you're getting the supply from. We know that babies don't have adequate amounts of adipose tissue to store these fatty acids. So what should we do? Well, ideally, we want to maintain the arachidonic acid to DHA ratio and maintain the linoleic acid to DHA ratio. We do want to avoid excess icosapentaenoic in the first week. Maybe we shouldn't be using fish oils in the first week or two. We want to minimize the intravenous lipid emulsion used by starting early feeds and giving mums only milk. But we don't really know yet whether you should be giving supplements. Fetal accretion is complex. In the fetus, metabolism is tightly regulated between the two N3 and N6 fatty acids. High maternal intakes in pregnancy actually decrease fetal tissue levels of arachidonic acid, which is quite interesting. So in summary, it's really not clear what the best strategy is for preterm babies. Let's just have a look at the trials that have been done. These have been summarized by Bilal Al-Sheikh from Calgary in Canada. He found 15 RCTs in preterm infants, all of them with important methodological differences, depending on whether the baby is receiving formula milk, human milk, or both. Differences in birth weight, gestation, the intervention, the dose, what the control product was this a placebo or some other oil, the definitions of the outcomes and study qualities you can see from this Cochrane plot here of bias. So lots of difficulties in meta-analyzing this data. There have been studies of RCTs of supplemented formula with DHA and sometimes with arachidonic acid. I'm not going to go through these in detail, but most of these are pretty underwhelming, if I'm honest. But there is some very interesting results in the studies where DHA or DHA and arachidonic acid has been added to milk. These are the Swedish Megadonna study looking at retinopathy, which I will show you. The Canadian Moby Dick study where they gave DHA to the mother. The Australian trials of Maria Mercedes and group giving extra tuna oil DHA to mum or to the babies. So lots of studies here. I'm not going to be able to go through all of these in detail, but just to give you an idea of where we are. But this is the key study. This is the study where they gave extra DHA to babies born less than 29 weeks compared to placebo. And the primary outcome in this study was full-scale IQ at 5 years of age. So this was a very large trial with over 600 babies. And they were able to follow up 480 out of 600 at 5 years of age. I think that's really quite impressive. And what they found was a 3.5 IQ benefit for having the DHA supplement. That is really significant. A lot of people said, well, it's only 3.5 IQ points, but I know of no other nutritional intervention in preterm infants that does that, with the exception of comparing mother's milk to formula. And there were no real adverse events. So this does suggest that DHA might be beneficial for brain development in preterm infants. There has been a small kind of systematic review of this by the Australian group. What you can see here is that high-dose DHA supplementation has virtually no impact at 2 years of age. As I said in previous talk, I don't think the 2-year Bailey outcome is a very robust outcome measure for nutritional interventions. But when you look at later outcomes, there really are only 2 trials here. It's the Neurodevelopment supplementation group and the DINO studies where they supplemented the mums. So the DINO studies, which were smaller, the mums were supplemented, we may have seen higher rates of BPD, really don't show any impact on the Bachelor measures at 5 years of age. But when we look at the direct DHA supplementation in the Neuro studies, we see this 3.5 point advantage in the babies at 5 years of age. So overall, maybe not an effect, but when we just think about the DHA studies, it does appear that we need to think about this. But there's only 3 RCTs with about 2,000 babies. As I said, no differences at 2 years of age, really. But these important benefits at 5 to 7 years of age with a reduction in mild cognitive impairments, higher Bachelor scores, no negative impacts, but lots of heterogeneity in the different methods in the studies and only a relatively small number of RCTs. So as I say, the Neuro study where they gave 60 milligrams of DHA, there was a higher full-scale IQ at 5 years of age, but where they supplemented the breast milk by supplementing the mothers or the formula, they showed no benefit at 7 years of age. So been lots of other systematic reviews. This one includes other infants as well. Here they found 20 RCTs that looked at the role of DHA supplementation in these trials, and then used different Bailey outcomes, visual acuity. And so of these 20 RCTs, 9 were conducted in pregnancy, 2 were postpartum, 7 were infant supplements. Most of these were conducted in high-income countries, but one of the studies was from Mexico and one was from India. In summary, if you look at visual acuity, really no impact at all. Language skills, really no impact at all. Behavior, really no impact overall at all. When they looked at risk of bias, there's an unclear risk of bias in quite a lot of these studies, so some methodological concerns. And in these funnel plots here, you can see that the funnel plot is quite asymmetrical. So I suspect there are some smaller studies of fatty acid supplementation that have shown a negative impact, and therefore people have chosen not to publish them. So overall, no impact on the MDI for subgroups, but for the PDIs, for psychomotor developmental index, there might be a small advantage that appears when you start putting all these studies together. So there is this possible benefit on neurodevelopment in infancy, but really it's the impact at 5 years of age from the Neuro studies. What about BPD? Should we be concerned about this? And are there any other adverse effects? So again, looking at RCTs in preterm babies, now we're looking at babies less than 35 weeks, not just less than 29 weeks. But they looked at 11 trials, and they did show this consistent, slightly higher rate of BPD increased by about 10%. But when they looked at those without the arachidonic acid, you do see the higher rate, suggesting that if you give the arachidonic acid and the DHA together, you might not see the same impact on BPD. But when you put them all together, no significant effects on retinopathy, neck, sepsis, or mortality. Should we be concerned about this 10% increase? Well, again, Bilal Al-Sheikh has put all this together. Dang has put this all together. So there does seem to be an impact on higher BPD. I think probably there is something going on there. That might be because these extra fatty acids result in lipid peroxides or other pro-oxidant compounds. And it may be because we're disrupting this anti-pro-inflammatory balance in the babies. But when the Canadian and Australian groups went back and looked at their data, they noted that BPD was very poorly defined. And when you look at severe BPD, when you tried to meta-analyze the studies, there were only 2 trials that did that. So these were the Moby Dick Canadian study and the Australian Neuro study, 2,000 babies, so quite a lot of babies. And when you look at severe BPD in this group, there was actually no difference between DHA and placebo. So no difference in mortality or death or severe BPD, suggesting that maybe this slight increase that we see in BPD overall might be due to coding or might only increase mild BPD without having a long-term impact. So there does seem to be an important brain benefit without an increase in severe BPD. What about other outcomes of concern? Well, it's very likely that fatty acids might decrease necrotizing enterocolitis because of their impact on intestinal growth, epithelial integrity, immune effects, these types of things. So there has been a meta-analysis looking at babies less than 32 weeks and the impact on neck, and they looked at studies giving DHA as well as DHA and arachidonic acid. But you'll note here that big range of dosages between 40 and 120 in the amount. So putting all these studies together is quite difficult. However, when they did that and they looked at the sole supplementation of DHA, they do feel that there's an increase in the risk of NEC, but not significant if you just look at arachidonic acid. Indeed, if you look at the trials where you give DHA and arachidonic acid, it looks like the rate of NEC might actually be lower. As I said, you can get DHA from fish or algae, and it's possible that the source of DHA has an impact on later effects as well. If you look at the dose, let's say there was no clear association between the dose and the risk of NEC overall, but there does seem to be this adverse effect when you give high dose DHA to the mother, which seems to be associated with the borderline increase in NEC. So maybe maternal supplementation is not the way to go. Is this biologically plausible? Well, there's been a lot of studies in animals showing a lack of arachidonic acid increases the risk of ulceration, the duodenum and ileocecal valve. If you refeed piglets who've been made ischemic, giving them extra arachidonic acid improves recovery. If you give fish oil to piglets, you can limit the inflammatory response. And if you give DHA and arachidonic acid to rats, you can reduce intestinal inflammation. So there are lots of animal studies suggesting this might be important. There may be biological effects, such as NEC. But generally, the incidence of NEC in these studies is low. NEC is poorly defined. There's a lot of heterogeneity, so I don't think we really know. So sole DHA supplementation may improve the brain. Sole DHA supplementation might also increase the risk of NEC with no impact on mortality. But what other outcomes are important here? We might expect an effect on retinopathy, but interestingly, there was no effect on retinopathy in the Australian trials. But there have been these 2 recent trials in Sweden and Norway, which I'm just going to show you. So it's a very important study from Anne Hellstrom's group recruiting 200 babies less than 27 weeks gestation, so a very high risk group. Compare giving additional arachidonic acid and DHA from day 3 until term. There was no control, so this wasn't blinded. But what they saw was a dramatic halving in the risk of retinopathy. So 15% in the babies getting the supplements compared to 33% in the control group. Lower rates of ROP if you get arachidonic acid and DHA compared to control. And in this study, only 200 babies, but a decent size, no difference in the rate of BPD, IVH, or sepsis. So quite encouraging. The DHA and arachidonic acid might reduce retinopathy. This is a study from the Norwegian group, similar interventions, similar supplementations, but here they looked at brain maturation using diffuse tensor imaging on an MRI. 120 infants, they didn't see a difference in severe ROP, but probably they were underpowered, 5% versus 12%. No difference in neck. But what they do see is higher fractional anisotropy in the white matter tracts, which you pick up on MRI, particularly affecting the corpus callosum, posterior limb of the internal capsule, and certain other areas. So in this relatively small study, supplementation with arachidonic acid and DHA at doses that match the amount you would get as a fetus do appear to improve white matter maturation. Finally, what about post-discharge supplementation? As I say, the composition of early emulsions is probably critical, balance of risks and benefits, and the role of routine DHA supplementation is currently unclear. But if retinopathy is lower, should we be considering this combination in routine practice? Do we need more data? We do know that brain growth and development is rapid over the 12 months following discharge. So though we need more data for here, we also need more data in the post-discharge period. And we've been trying to look at that in what we call the dolphin trials, where the babies were given extra docosahexaenoic acid and choline to high-risk infants. And so in the first dolphin trial, these high-risk infants were term or preterm babies with intraventricular hemorrhages or term babies with HIE. And here's the data summarized in about 45 babies who they were able to get the outcome. And what you can see is this suggestion of an important cognitive benefit at 24 months of age. Didn't seem to be apparent at 12 months, but 24 months does seem to benefit for cognition, maybe language, no impact on motor development, and no impact on the Vineland questionnaire. So this follow-up of the study also looked at other psychometric testing. So at 6 months of age, they did what's called the infant fixation shift attention test. This is a test of visual attention. And then at 5 years of age, they did the early childhood attention battery, which is quite a complex test with a lot of components to it. But again, it measures attention and some element of cognitive function using the Kaufman ABC. Now, they only tested 33 of 55 babies at 45 years, so pretty small group. We shouldn't draw too many conclusions from this. The infant fixation test, you sit the baby looking at the screen and you show him black and white bars that look like a kind of face. And the babies will turn to something that looks like a face. And then an observer's looking through a little pinhole here, looking to see which way the baby's eye moves. So you have these alternating black and white bars that attract the baby's attention to either the left or the right. And then you record how long it takes for the infant's head to move and stay there. The early childhood assessment battery is quite complex. So one of them involves looking at a whole load of red apples, I think, and then trying to pick out the strawberry. One is the flank test, is the fish pointing to the left or to the right? Sustained attention test, you show the same 5 animals in a sequence and get the kids to point them out. And then you can also have something called a counterpointing test where you point to the dog on one side. So this early childhood attention battery, only 33 of 55 babies were tested, but what they showed was overall for all of the babies, poor attention compared to age-related norms. But they do see this improvement in the babies who are getting the DHA and choline supplementation. So reduced impairment for sustained attention in the intervention arm, which was significant for these different subsets, suggesting that there may be something beneficial in the post-discharge period. Black is the supplement, white is the placebo. You can see that the black scores tend to do better throughout. And we've followed this up with a much larger trial, also called Dolphin, but spelt differently. and we recruited babies with HIE and preterm babies from 30 neonatal units, and they were randomized getting extra DHA choline and a nucleotide base versus placebo until 12 months of age, with a primary outcome at 24 months. We were able to recruit over 600 preterm babies overall and over 200 HIE babies, and we will hope to have that data in about 2 years' time. So DHA and arachidonic acid reduces ROP, and some units have already started to use this, but I think we need much more basic science and more trials. We should think more carefully about the role of intravenous lipid emulsions on the NICU. We should encourage breastfeeding, and we should encourage a healthy diet for mothers and infants, but not necessarily supplements. Because at this point in time, I think we really don't know whether supplements are beneficial. So a very quick tour of the importance of fatty acids in neurodevelopment in early life, both for preterm and other sick infants. Again, I think the key message here is that we should be strongly promoting the use of mother's own breast milk, much more than donor milk. We should be encouraging healthy diets, but we don't really know at this point in time whether we should be giving extra supplements. However, following more trials, I would not be surprised if in 5 years' time the DHA and arachidonic acid supplementation becomes routine on the neonatal unit. Whether that is true after discharge, I don't know. So thank you very much for your attention, and I will stop the meeting there. So thank you very much.